There is a conversation that happens behind closed doors in surgical suites and continuing education seminars that almost never reaches the people who need it most, and it concerns a part of your body you have probably never associated with your face, the back of your knee. If you are sitting right now, reach down and press 2 fingers into the soft area directly behind your kneecap, into that hollow between the 2 tendons. Feel the tissue there. In most adults over 50, that tissue is dense, thick, resistant to pressure, in a way that the same spot on a 20-year-old simply is not. That density has consequences that travel much further than your knee, and by the end of this, you will understand exactly how far and exactly what to do about it. What surgeons discuss privately, and what I have observed across years of clinical work, is this. The layer of connective tissue they lift during a facelift procedure is not unique to the face. It is one segment of a continuous sheet that begins at the sole of your foot, travels up the back of your calf, crosses behind your knee, runs along the back of your thigh, ascends your spine, crests your skull, and terminates at your brow ridge. One unbroken fascial line. When a plastic surgeon tightens the facial segment of this line, they are working on the same tissue that wraps your calf muscle, the same embryological origin, the same collagen fiber orientation, the same mechanical properties. That fact changes the question entirely. If the tissue is continuous, then tension anywhere along the line affects tension everywhere along the line. And if you are losing tension in your lower face, the question is not just what is happening in your face. The question is where along this entire line did the tension leave? I want to tell you about a woman I will call R. She was a physical therapist for 34 years, retired at 61, and she came to see me not for her face, but for persistent stiffness behind both knees. She had treated thousands of patients over her career, knees, hips, shoulders, ankles. She had never once, in 34 years, treated a knee and considered the face. She told me that when I explained the fascial connection, she felt something close to embarrassment, not because she should have known, but because the information existed in the anatomy text she had studied and she had simply never been taught to read it that way. That reaction is why I think this matters. The anatomy is not new, the connection is not new. What is new is the way we are learning to read continuity instead of isolation. Let me take you to where this line begins, not in the body as it exists now, but in the body as it forms. In the first weeks of embryological development, 3 layers of tissue differentiate. The outermost becomes skin, the innermost becomes organs. The middle layer, the mesoderm, becomes everything structural: bone, muscle, and connective tissue. Here is the detail that matters. The connective tissue of your calf and the connective tissue of your face differentiate from the same mesodermal sheet. They do not develop separately and then connect. They develop as one continuous structure and remain continuous for your entire life. Thomas Myers, who spent over 2 decades dissecting and mapping these fascial continuities, demonstrated this in full-body dissections, where a single fascial line could be lifted from the sole of the foot to the forehead without a single cut. One piece, not connected, continuous. This distinction between connected and continuous is critical. 2 ropes tied together are connected. 1 rope is continuous. The mechanical behavior is entirely different. In a continuous structure, tension applied at one end transmits to the other end with very little loss. In a connected structure, the knot absorbs force and transmission is partial. Your posterior fascial line is 1 rope. So when I say that what happens behind your knee affects your face, I am describing mechanical force transmission through a continuous collagen matrix. Not a theory, a physical property of the material itself. Now I need to explain what goes wrong at the knee, because the knee is where this line most commonly fails in people who sit for significant portions of their day. Behind your knee is a space called the popliteal fossa. 2 muscles converge there, the gastrocnemius coming up from the calf and the hamstrings coming down from the thigh. Each muscle is wrapped in fascia, and where they converge, the fascia from both muscles share space in a very small area. In a body that moves frequently and varies its positions throughout the day, the fascial layers in this space remain hydrated, mobile, and distinct from each other. They slide past one another the way 2 sheets of wet glass can slide. The fluid between them, called hyaluronic acid, provides the lubrication. In a body that sits for hours, something different happens. The knee stays in a bent position. The fascial layers in the popliteal fossa are compressed together. The hyaluronic acid between them begins to lose water content. Dr. Carlos Stecco, whose cadaveric dissection work at the University of Padua has done more than perhaps any other research to illuminate fascial layer behavior, demonstrated that hyaluronic acid concentration and viscosity change significantly with sustained compression. The fluid becomes thicker, stickier. The two fascial layers that should slide independently begin to adhere. This adhesion is not dramatic. It is not an injury. You would never go to a doctor for it. What it does is subtle and cumulative. It creates a point of increased density along the posterior fascial line, a point where tension transmission is impaired. Think of it in purely mechanical terms. If you pull on one end of a rope and there is a section in the middle where the fibers have matted together, the force arriving at the other end is diminished. The rope did not break. It became locally less efficient. Let me be more direct about what this means for your face. The superficial musculo-aponeurotic system, the SMAS, is the fascial layer that plastic surgeons manipulate during a facelift. It is the structural layer that gives the lower face its contour, jaw definition, the angle beneath the chin, the transition from cheek to neck. When surgeons describe the SMAS, they describe it as if it exists only in the face. But the SMAS is the facial terminus of the posterior fascial line. It is the same tissue. Its tension depends in part on the tension of the entire line beneath it. When the fascia behind the knee becomes adhered and dense, the tension available to the SMAS is reduced, not eliminated, reduced. The effect is not the primary cause of facial aging. Gravity, collagen degradation, fat pad descent, bone resorption all play larger roles, but the fascial tension component is the one almost nobody addresses, and it is the one you can influence in 60 seconds with your own hands. R told me something during her third visit that I've thought about many times since. She said that for years she had noticed a heaviness in her lower face that worsened through the day, and she had attributed it entirely to aging. She had never connected it to the fact that the heaviness correlated almost perfectly with how long she had been sitting. Morning lighter, evening after a day at the desk, heavier. She had the clinical vocabulary to describe the mechanism once it was explained to her, and what she said was, I was treating the downstream effect in every patient I ever saw, and I never once looked upstream. That sentence contains the entire principle, downstream and upstream. Your face is downstream of your posterior chain. Your knee is upstream of your face. Here is where I want you to assess your own situation before I give you the protocol, because this is not one size fits all. The degree to which fascial adhesion behind the knee affects your lower face depends on several individual factors, and 3 questions will help you determine where you are. First, sit in a chair with your feet flat on the floor. Press your thumb firmly into the center of the space behind one knee. On a scale from soft and mobile to dense and resistant, where does the tissue feel? If it feels dense, almost gristly under your thumb, you likely have significant fascial adhesion in that area. Second, pay attention tomorrow to whether your lower face feels different in the morning versus the evening, specifically after prolonged sitting, not in the mirror from the inside. Does the area along your jawline and beneath your chin feel heavier, more congested, less defined after you have been at a desk for several hours? If yes, you are feeling the fascial tension loss in real time. Third, press behind your knee for 10 full seconds with moderate pressure, then release. Do you feel any sensation that seems to travel upward? A warmth, a loosening, a subtle shift that extends beyond the local area you pressed? If you feel something, your fascial line is responsive to mechanical input, and the protocol will likely produce noticeable results. If you answered yes to all 3, you are an ideal candidate for the full 60-second protocol. If you answered yes to 1 or 2, the modified version I will describe afterward is your starting point. If you answered no to all 3, your posterior fascial line may have less adhesion than average, or the adhesion may be at a different point along the chain. I will address that as well. The full protocol. Sit on a firm surface, a wooden chair or a bench, not a sofa. You need a surface that does not absorb the pressure you are about to apply. Place a tennis ball or a lacrosse ball behind one knee, directly in the center of the popliteal fossa. You will feel it settle into the space between the tendons. Now slowly close your knee, bending your leg so that your calf presses the ball deeper into the space behind the joint. The pressure should be firm but not painful. A 6 out of 10 on a pressure scale. Hold this position for 30 seconds. During those 30 seconds, slowly point and flex your foot 3 times. This movement causes the gastrocnemius to contract and release against the ball, creating a shearing force between the fascial layers that helps break the adhesion. After 30 seconds, open your knee, reposition the ball slightly to the left or right of center, and repeat for another 30 seconds. Total time, 60 seconds per knee. What you are doing mechanically is applying sustained compression to dehydrated hyaluronic acid between fascial layers combined with active shearing through muscle contraction. The compression forces water back into the ground substance. The shearing separates layers that have begun to adhere. Dr. Stecco's research group measured changes in fascial layer sliding within 3 minutes of sustained manual pressure in living subjects. 60 seconds will not complete the process, but it initiates it. Consistency over days compounds the effect. The modified protocol for those who answered yes to fewer than 3 questions. Same position, same ball, but reduce the pressure to a 4 out of 10 and hold for 20 seconds per position instead of 30. Skip the foot point and flex. Just hold. You are introducing the tissue to mechanical input gradually. After 2 weeks, reassess with the 3 questions. For those who answered no to all 3, your monitoring protocol is simpler. Once a day, press your thumb behind each knee and notice the tissue quality. Do this for 1 week. You are training your proprioceptive awareness of an area most people have never consciously felt. After 1 week, try the modified protocol and notice whether anything changes. R followed the full protocol daily for 11 weeks. Her results were specific and I think honest in their incompleteness. The heaviness she had felt along her jawline in the evenings diminished significantly. She described the tissue under her chin as feeling less congested, which in fascial terms translates to improved sliding between the platysma and the underlying SMAS layer. Her morning facial puffiness, which she had attributed to sleep position, reduced. She felt a difference in how her jaw moved, less resistance when she opened wide, less clicking in her temporomandibular joint. What did not change? The deeper nasolabial folds that had developed over decades, the volume loss in her midface, the skin laxity that comes from intrinsic dermal aging. She did not look 10 years younger. She looked like herself with better tissue quality in her lower face. The lines were the same. The heaviness was less. She told me that the change she valued most was one she had not anticipated. She stopped clenching her jaw at night. The connection between posterior chain tension and jaw tension is well documented, and when the fascial line regains some of its resting tone, the compensatory clenching that her jaw had been doing to create stability became unnecessary. That is the honest result. Partial, specific, measurable in sensation more than in appearance. Valuable not because it reverses aging, but because it addresses a mechanical contributor that accumulates silently over decades and that almost no one thinks to address. R has a daughter who is 38. She sits at a desk 9 hours a day. R taught her the protocol and told her something I found deeply precise. I am not giving you a beauty trick. I am giving you 30 years of tissue quality that I did not know I was losing. The bodies we inhabit carry the postures of the lives we live, and those postures accumulate in the fascia long before they appear in the mirror. The generation that understands this will age differently, not because they found a secret, but because they maintained a system that previous generations did not know was degrading. The next time you stand up from your desk and feel that familiar stiffness behind your knees, you will know what it is, not just stiffness. Fascial layers losing their independence. And you will know that the face looking back at you in the bathroom mirror is in part a reflection of what is happening in that small space behind each knee. 60 seconds, a ball, consistent pressure. The protocol is simple enough that you will either do it or you will not, and the only voice that can make that decision is yours. R told me one more thing in the hallway, not during the appointment. She said she wished someone had told her about posterior chain continuity when she was her daughter's age. Not because it would have prevented aging, but because it would have changed the way she understood her own body for 40 years. Some knowledge does not change what happens. It changes what you notice while it is happening. And noticing for R turned out to be the part that mattered. I think about that conversation often. The one that happens behind closed doors. The one about the tissue that runs from your feet to your forehead. It is no longer behind closed doors.